Thank you, everyone. And now we'll move to the final segment of this evening. I'm Meghashi Sharma from the Gupta-Klinsky India Institute. And after that engaging discussion on US-India higher education partnerships, we'll move to the next segment, which is focused on TB. Tuberculosis, as we know, is a critical public health challenge to which significant morbidity and mortality is still attributed to. While TB management is complex, the disease is exacerbated in children and adolescent population. Despite possessing a greater global burden of TB, India has made significant steps towards TB elimination through advanced programming and deploying technical strategies. To give us more insight on India's TB elimination efforts, I'd like to call upon stage our esteemed guest for the evening, Dr. Urvashi Singh, Deputy Director General at the Central TB Division, Ministry of Health and Family Welfare. Welcome, ma'am.
So good evening all. I must thank Dr. Amita Gupta for the invite today, and of course Johns Hopkins. These stories we heard, all of us have some friends that we worked with, but Hopkins has a special place with all of us. Talking about the TB burden, India contributes a significant number to the TB patients world over. But the progress that, in fact, was noted in the WHO TB report, the global TB report that got released just last week, when we compare that to the world, we feel, it's a moment of pride for us to actually look at the development India has done over the past few years. So the SDG targets gave us 2015 as the baseline, and what the global TB report, if I may refer to the numbers that have been highlighted, India has been able to bring down the incidence by about 17.7% to be precise, while the rest of the world has lagged behind, about 8.3% or around that figure. Again, a reduction in mortality has been noticed, which is to the tune of about 16% over this much time. Now, what all of us are aware of was the problem that COVID actually brought in. Before that, our progress with reporting of cases, with the treatment coverage was actually doing very well. In fact, if I bring to you the numbers of missing millions, we call the cases which are the gap between estimates of TB and the actual incidence was much higher earlier, and we brought it down to much less. We barely have about 2 lakh cases which are not being reported, of a burden of about 28 lakh reported in India in 2023. Now, the progress that we've been able to make, again, this was highlighted in the global TB report, that there is an immense support from the domestic within India budget, which is contributing to the growth. In fact, 91% of our TB budget is supported by the domestic budget, while we have some development partners which continue to support us, like USAID, BMGF, and of course, we've had collaborative work with Hopkins, Harvard, under the report group, which Dr. Amita has been part of from the very beginning. So such collaborative research work goes on. I was listening to the previous talk where they talked about collaborative research. And in TB, we have seen this for a long time, where DBT funds the India partner in the report group and NIH funds the US partner. So collaborative work has always been on, and I think today we are here to look at another initiative that Hopkins is taking, to look at the TB schools initiative, TB-free schools initiative, where, let me apprise you of the burden of TB in children is to the tune of about 3.3 lakhs annually. And I was referring to the efforts that India has done and the domestic support for us. So the growth, of course, if one looks at the 28 lakh numbers, is huge. But then what we are now trying to do is try to bring in all the TB patients into the program fold so we can address the problem, take care of these patients. So let me allude briefly to the kind of work the program has been doing. So we have been able to expand our molecular diagnostic network throughout the country. We started with 715 molecular diagnostic machines in the year 2015, and now we have increased it to about 10 times. We have about nearly 8,000 NAT systems across the country. We have a wonderful screening tool, that is the X-rays. We have a good network, but of late we are now concentrating on acquiring handheld X-rays and covering each district with at least one handheld X-ray. And possibly with time, so this is what I'm talking today within this year, possibly with times we'll be able to provide at least 2 handheld X-rays to each district and try to reach every block. Now our National Health Mission, that is the NHM, is trying to cover each Ayushman Arogya Mandir, where again TB is going to be an inherent part of the health system, and the services are growing and becoming stronger every day. There are additional services that are being added while the meeting goes on. There are services like ENT care, eye care, mental health care, and care for the elderly, which is reaching the Ayushman Arogya Mandir. So in every sense of the word, India is progressing. And coming back to when I was talking about our screening tools and our diagnostic tools, which are NAT, the children in this, despite the best of tools, have a different presentation. So as you may all understand, the immune system is not as well developed. Hence, the presentation of a child or an early adolescent patient may not be the same as an adult patient. Hence, we sometimes are, looking for a better tool, a smarter tool, even better than the molecular diagnostic tool, because it's not always that a child will have a similar presentation to an adult. It's not always that a NAT system may be successful in a child. Also, the treatment in a child is much more, the child needs more care. So first, there's an issue with diagnosis. And of course, the screening tools, X-rays, may not always pick up a chest lesion, because the chest lesion may not be typically as, an adult chest lesion would be. So we're always looking for newer tools. And this is where, when Dr. Amita's group approached us with the TB Schools initiative, we always believe we may be doing very well, but nothing like having all hands together, everybody who's passionate to deal with TB on board with us. So we are thankful to the idea and the group's initiative to come on board with us, though I would like to say the program is strong, but when hands join, we become stronger. And again, of course, which schools they will enroll, they have a model depending on the burden. They will decide which schools come on board and which areas they're going to cover, which I'm sure somebody would be covering with you shortly. But the idea is to look at new research tools. For example, we looked at the urine lamp tool way back in 2013-14. We started this research. I happen to be a professor at AIIMS with additional charge of the National TB program. So we did this urine lamp, which was found very useful, not only in picking TB in pulmonary, but also extrapulmonary sites in children. Again, looking at such tools, and then we've done a study with FIND where we looked at stool NAT, and last year we published on, I'm not really sure how many of you are TB specialists, but since this is an area where, new research or new technology can come in to help us, especially in children. We published something in the area of looking at DNA in the urine. So in addition to stool, we published in urine, diagnosing children with newer tools. So I think I'm trying to talk about several things which may appear new to a lot of you. lot of the people present here. The program is actually trying to take in new technology for, so our strategy has changed recently. I took over the program about 3 months back, 1st of August. So our strategy is now changing to reduction in TB mortality due to TB, as well as reduction in TB incidence. That's why I talked about the network of tools which are available to us. We're going to actually reach out in a campaign mission mode to the high burden areas where, again, this TB school initiative, TB free school initiative will contribute. So you may have read in papers regarding the newer regimen we're rolling out. That is the BPAL-M regimen, which is shorter regimen for treating MDR TB. Similarly, we'd be hopeful if some good new shorter regimen can come in for DRTB, for DSTB. If something comes up for children, we are open to that. Now, in the campaign mode, I'd briefly allude to, we're going to have all the tools on board. We're going to go to the periphery. Some newer publications have actually brought out risk groups, that is the high burden groups, which contribute to about 80% of TB in our country, which includes patients with lower BMI, which includes patients who have had TB in the past, older age group, smokers, alcoholics, diabetics, and people living with HIV, to name the top few high-risk groups. So what we intend to do in a campaign mode is to go and screen these patients using an X-ray, followed by confirmation by a molecular tool. Earlier, what people would do is look for symptomatic TB. And what has come to light with recent evidence is all TB may not be symptomatic. Patients may have subclinical TB, which may soon become florid TB, and such patients may not have the classical symptoms of cough, and so on and so forth. So we have changed our strategy, and we're going to look for the presence of subclinical or active TB in an intensified fashion in high-risk groups. In addition, we'll screen communities with symptoms, patients who do not have any immunocompromising situation, may have symptomatic TB. So there we'll have the classical approach of looking for symptoms followed by X-rays and confirmation by NAT. So this is going to be launched soon, early December, and we're going to cover nearly half of the districts in the country, about 347 districts. And that this is, we initially call it a 100-day campaign, but if we find the fabric of the campaign being helpful in bringing in more patients, which is actually the effort being brought to you today, where the group from Hopkins is going to only look at school children. And I was requesting to them cover as many schools as you can, because in the campaign mode, children, of course, we'll try to screen, but something as targeted, as defined, as looking for TB in a school will be very helpful. Children, as the pediatricians always complain, are often left out when public health programs are rolled out for some reason or the other. And one of the reasons I alluded to earlier, that the TB presentation is not very classical. They present a little differently than the adults. So I would like to thank the group who brought in this initiative, and the program will be always supportive of any effort towards finding TB. And again, like I said, I'm thankful for the initiative, because I think every effort towards TB only strengthens the program's efforts. So thank you, and thank you the team from Johns Hopkins for having me here. Thanks again.
Thank you, Dr. Ubashi. Now I would like to request Dr. Amita Gupta, Director of the Division of Infectious Diseases at Johns Hopkins and co-founder of the Gupta-Klinsky India Institute, to share more details on the Pediatric TB Schools initiative.
Great. Well, thank you, everyone. It's been a marathon, so I will try to keep my comments short. First of all, thank you so much for your incredible attention and interest in our projects. And thank you, Dr. Singh. Dr. Singh is a world-renowned TB expert who came from AIMS, as she said, New Delhi, and is a clinical microbiologist, and now has taken this really important role for the government, leading the TB control program in India. Now, how many of you, just raise your hands, know somebody who's had TB? Just raise your hands. Okay, that's a lot of you. Now, if I did that in the United States, I would get very few people raise their hands. So I know that you heard the amazing progress that's been done here in India in terms of decreasing incidence, but we still have more work to do. And that's why we've partnered with Dr. Singh, the Indian Council of Medical Research, with private sector, with public sector, and with academicians to really launch this new and exciting initiative to help inform the policy of the government of India of how can we best screen children. How do we do this cost effectively? You heard that they have different presentations. So basically what we've done is we've come up with a simple research protocol where we're going to identify high burden schools, identify children in those schools, and ask them, do you have symptoms? Have you ever known anybody who has TB? We're going to then place a simple cost, very low expensive skin test called SciTB. We'll also do an AI-generated chest x-ray. That's the portable chest x-ray that you can do right in the school, classroom, or gymnasium. And with all of that information, decide what kind of treatment or decision we need to make for that child. So it's going to be a simple study to look at how cost-effective, how many children will we find that have active disease, how many children have what we call latent infection, meaning they've been exposed and have evidence of the disease but don't have symptoms, and we're going to offer treatment. So with that in mind, I want to thank the commitments of our partners for the Gupta-Klinsky India Institute, and you'll see a wonderful video where we really sort of illustrate the importance of this project, and want to thank the partnership with the government of India, with our NGO partners, and with all of you for your time and attention, because we need to work on fighting TB together. That's the only way globally. If we find solutions here with India, we will be finding solutions for the rest of the world. So we're really excited to share with you this exciting new initiative. So over to the team to show a video. Thank you. So I hope you were inspired by that video and will join us in our fight against TB. We really look forward to partnering with all of you in any which way, your knowledge, your interest, your enthusiasm, your volunteerism. Come help us fight TB. We are going to succeed in really making a difference across the nation. Thank you so much.